So let's review some of the evidence and why we're doing this. A lot of people will say that the transthoracic echo sensitivity and specificity is quite poor, and historically that was true, but there's been some new data coming out to say that this is better than we thought, and really can save a lot of time, and possibly time to operating room, time to procedure, time to CAT scan, all those sorts of things to get these people exactly what they need as soon as possible. Our story starts in 1988. In France, we had the Rudow study, where they had quite a number of people, 128 dissections out of 673 suspected dissections. And they found that dilation of the aortic root was 95% sensitive. The linear dissection flap inside the lumen was 98% specific, and also had a very high negative predictive value. And then the long axis for that flap had a 100% positive predictive value, while the short axis, like I mentioned before, was significantly less. Pericardial effusion was specific but not sensitive, and same for aortic regurgitation. So those were pretty promising. However, that wasn't replicated again for quite some time. The IRED study came out in the meantime, back in 2002, and really focused on transesophageal echo as well as CT scan, and that's the majority of the cases that they had. And you can see that the CT was more sensitive and specific than transesophageal echo, but transesophageal echo was not far off. In 2012, Moreno had the first study since 1988 to really dive into this again, and again showed for these aortic syndromes, again trying to encompass more than just dissection, the sensitivity and specificity was in the 90s for transthoracic echo for these problems. Now, Piemanizari, this guy, has been doing studies related to ultrasound and aortic dissection for about the past decade. He ended up doing the study that I thought I wanted to do based on some of his research, but obviously since he was the one doing the research, he knew what direction he was going, and then put out the study that I wanted to do, and then I was sad. So in 2014, he started with trying to look for TTE and dissection and look at the sensitivity and specificity. Things were not looking super hot, didn't reach 90% in what he was looking for. So again, we segment this out to direct signs and indirect signs. For direct signs, the sensitivity was 54%, so that's pretty bad. The indirect signs were a little better, the dilation of the aortic root being the most sensitive of the indirect signs, and the others pretty far behind. Any sonographic sign of any kind had a sensitivity of about 88%, which is not terrible, but we really like to be over that 90% threshold to really incorporate it into clinical practice. So, like any good EM clinician, he added a risk tool to try and segment out who needed what and how we could try and avoid CTAing all these folks. So he created the aortic dissection detection risk score, which of this entire lecture, this is one of the most clinically relevant things, I think. It uses a risk tool plus a D-dimer to try and figure out who needs a CTA versus who does not. It also is a really great way to take a good history and physical of someone who's concerning for aortic dissection. So you get your risk factors, you got your pain features, and then you got your high-risk exam features. And it's a 3-point score. Anything that's greater than or equal to 1 would be more concerning. So when they added the risk tool, the sensitivity and specificity significantly jumped when we're talking about any kind of sensitivity, with ultrasound. So we have the risk tool, the ultrasound put together, and we get a sensitivity of 96% if you look for any sonographic sign, including indirect signs. And then specificity jumps to 98% if you specifically have a direct sign. You see the flap, you see the intramural hematoma. So there was another study by a colleague in Philadelphia back in 2017. They're still working on trying to collate this data into a better study. This is more of a poster presentation, but what they found was a sensitivity of 96% and a specificity of 91% for their study of, they had 442 total patients, and I think it was around 28 or so had some kind of dissection. So Nazarian comes in again in 2019 to do a sub-analysis of a big study that he did for aortic dissection, which is where we got those original numbers of 96 and 98%. That was the advised trial, which was a multi-center trial out of Italy, and I think there was some sites in France and Switzerland. So they did a sub-analysis of all the patients who'd gotten an ultrasound, and found that the overall sensitivity and specificity, that if you got the dimer, the ADDRS risk tool, and the ultrasound, you could finally get to a sensitivity of 100%. The European Heart Association endorses this and has this in their recommendations. However, the United States AHA does not, and the Society of Chest Surgeons does not have it in their recommendations either. So it's not quite across the pond to us, but just be aware that this is a possibility. The way that they did this was pretty intense. So you can see their protocol on the left side, where not only did they get the peristernal long, the peristernal short, they got carotid views, they had the subxiphoid, they did a bunch of abdominal views, they got iliac views. This protocol took some time. And in the emergency department, I don't think that's really something we can do effectively, quickly, and then also have high quality sensitivity and specificity. The protocol they came up with based on this was they did the risk tool, then they did the ultrasound. If the risk tool was greater than 1, go straight to CTA, get your surgeon, possibly involved. If it was less than or equal to 1 and the ultrasound was negative, you could dimer them. If the ultrasound was less than or equal to 1 and you had a indirect sign, you could consider going either direction with a dimer. But if they had a direct sign, they would go straight to CTA and surgery consult. Now, more recently, there were a couple of residents in China who did their own prospective analysis of a bunch of patients that they were concerned for. They were getting a CT scan for aortic dissection, so they would just do an ultrasound before they went for their CTA. And they found that their sensitivity and specificity was 86% and 100% specificity. Their protocol was slightly more simplified, but they were also looking for other things. So if you look on the left side, you have looking for PE with RV-LV dilation, D sign. They were looking for ejection fraction. This was kind of beyond just looking for the aortic dissection itself. But most of the time they were looking at, is the aortic root greater than 4 centimeters? And was there a flap? And if either one of those was true, they counted it as a positive and moved on. And I think that's really nice for most people, is that, like, I need a simple way to look, and I need to know what I'm looking for, and it can't be that hard to look for it. So, like, putting color flow for aortic regurgitation is beyond most people's ability. Measuring the aortic outflow tract can take some time and may not be accurate for most users. And so looking for an actual flap in the lumen seems to be like that's the thing I wanted to use to try and make my decisions, because when I've had these patients, that the flap is what gave everything away. And that's when I initiated all the things and got vascular involved. I got, I called CT to let them know this patient was coming emergently, put in the override for contrast and all this other stuff. So again, the sensitivity and specificity is pretty good. Just be aware that the AHA and CHEST have not put this into their guidelines yet. And so I would still use CTA as your definitive test. But what we found is that the ultrasound can really save time. So this was a 2015 study looking at time to intervention and time to CT scan, and found that they were significantly lower when someone had an ultrasound done compared to those who did not. So this is really a time saver, and that's what I find in my own clinical practice that this really does, is that if I'm looking like, yeah, he says it radiated to his back, but he looks fine, he doesn't have a pulse deficit, he has no risk factors, he looks great, he says everything resolved, that's no longer ongoing. It's like, let's just do an ultrasound real quick, let's see what's going on with the aorta. If it's negative, like, he can wait for his CTA. If it's positive, then obviously, lights and sirens and everybody gets all excited.